Well, it's a pleasure to be here with you today. And my name is Dr. Bonilla. I'm a nephrologist. I'm a kidney doctor at the University of Chicago. And today I want to talk to you about scleroderma renal crisis, right? One of the most important and uh, most dangerous complications of scleroderma. So, scleroderma renal crisis is a life-threatening condition uh, with a mortality very high, depending on the country, but in the United States, about 20% at 6 months. It was once the leading cause of mortality in patients with scleroderma. But since we found the ACE inhibitors, which is one of the medications we use to treat a scleroderma renal crisis, that mortality rate has dropped significantly. So what is this scleroderma renal crisis, right? It's very sudden. It's a severe complication. It involves the kidneys and is characterized by increased blood pressure, right? Blood pressure that is uncontrolled, blood pressure readings that are in the 200s, more than 180s. It's a medical emergency. Patients needs to be admitted, and they usually need to be admitted to the critical care unit. It can lead to kidney failure very quickly. So in its prompt intervention, early intervention is key for preventing chronic damage to the kidney and permanent damage to the kidney. It needs rapid treatment, and early detection saves lives. If you have any questions, feel free to interrupt me during the talk. I know there might be some medical concepts that I might not naturally explain to you. So if you have a question, just interrupt me. So let's talk a little bit about the history of a scleroderma renal crisis. So it was first described in Auschwitz in 1863. They describe a patient who died rapidly with thickened skin and uremia. Uremia means when the kidney has failed and all these toxins that the kidney used to clean, they accumulate in the body, and it causes this syndrome called uremia. Patients become altered. They're not aware of what's happening. They have asterixis, which is tremors of the hands. In the late 1930s, some of the histological hallmarks of a scleroderma renal crisis were described, which is intimal hyperplasia. Hyperplasia means something that has thickened, right? Has grown. Intimal is one of the layers of our blood vessels. Our kidneys, they're made of a tuft of blood vessels, right? So that's why scleroderma can affect the kidneys. There's also fibrinoid degeneration and in the arteries in the kidney, right? The kidneys have arteries too that supply blood. That is very important for the normal functioning of the kidneys. And then the term renal crisis was coined by Moore and Sheehan in 1952. And the treatment of a scleroderma renal crisis historically has been an approach to treat that blood pressure, right? Antihypertensive therapy, they used to use these old drugs like methyl-dopa or propranolol. Sometimes we have to use dialysis. Dialysis is a treatment for renal replacement. It means that your kidneys have failed completely, that your kidneys are not able to do their normal function, which is clean toxins. Make sure that you're not volume overload, that you don't have too much fluid. They help with the blood pressure management. They help with anemia too. So when your kidneys have failed, we use dialysis, which is a process where your blood is taken out, passed through a filter, and then we return that blood back to you without toxins, and we get rid of some of that fluid. So mortality significantly reduced with the introduction of ACE inhibitors. ACE inhibitors means angiotensin converting enzyme in the 1980s. And I have a slide later on where I'm talking a little bit about how ACE inhibitors work and why they work on a scleroderma renal crisis. So how common is this, right? It usually happens in the first 5 years when patients are diagnosed with a scleroderma. There are certain high-risk characteristics that we're going to talk about. But in the United States, look at that prevalence, right, or incidence, 16 to 20%. And some countries in Europe is more than 20%, but some other countries have been able to manage that, and it's less than 5%. So it's still very significant. And again, this is a life-threatening condition. If it happens, it's an emergency, and patients need to be admitted to the critical care unit. So who is at risk? Patients with diffuse cutaneous systemic sclerosis, rapid skin thickening, and this is very important, patients who are positive for anti-RNA polymerase III antibodies. Patients who are on high dose of corticosteroids are also at risk to develop a scleroderma renal crisis because their high dose of corticosteroids will lead to sodium and water retention, and that will make your blood pressure worse. If anyone has ever been on corticosteroids, you'll notice that when you're taking it, you get a little bit of energy, but then as you continue taking them, then your legs get swollen, your face gets swollen too, so it's that sodium and that water retention. This water always follows sodium, so blood pressure will worsen in patients who have high dose of these medications. And then patients who have new or worsening anemia, they're also at high risk to develop this condition. So how can we recognize the symptoms, right? There's going to be an abrupt onset of moderate to marked hypertension, meaning high blood pressure, right? Whenever you go for your controls with your doctor, you get your blood pressure measure, so you know what's your baseline, right? You should know what's that baseline because it's very important that any changes in that measurement of the blood pressure could be like a hint, an indication that you might be at risk to develop this renal crisis. Sometimes it comes with other symptoms like retinopathy, right? For that high blood pressure being that high, it will cause effects in the eyes, and you can have this hemorrhage and exudates. Some patients become altered and they have hypertensive encephalopathy, which means that the high blood pressure has affected your brain, right? And you're not recognizing anything, you're not responding, you become altered. Acute kidney injury, that means that how we measure our kidney function is that we look at something in the blood called creatinine. So the creatinine comes from our muscles when it breaks down the protein, and the kidney secretes that in the urine. So we think that when the creatinine goes up in the blood, it means that our kidneys are not able to pee that out, right? So it's an indirect marker of kidney failure. So acute kidney injury means a change in that creatinine of more than 0.3 milligrams per deciliter that has happened suddenly, that is no more than 3 months. And then a normal urine sediment, that means that the kidney doctor will take a sample of your urine, is going to put it in a centrifuge, it's going to spin it, and it's going to leave a sediment. Then we examine that sediment under the microscope, and we look for cells, we look for other causes of kidney injury, right? So a normal urine sediment means that we haven't found anything in that urine that will tell us an idea of other etiology for your kidney failure, right? So those are the symptoms of a scleroderma renal crisis, right? High blood pressure, a kidney failure, and really no other explanation for that. Some other symptoms that patients might have are shortness of breath, edema, swelling of the legs, decreased urine output because your kidneys are failing, and chest pain. Why the symptoms sometimes could be missed? It's because high blood pressure is silent, right? When you have hypertension, most of the time patients don't have symptoms unless it's very elevated. So if you're not monitoring your blood pressure at home, then this might be missed, right? And at times also the symptoms might be mistaken for something else, right? If you're having a little bit of elevation of the creatinine, if you're not seeing a kidney doctor, then maybe that other doctor is not going to be able to catch that on time, right? So always that difference from creatinine of more than 0.3, it is significant, and you should question your doctor, hey, are my kidneys okay? Do I need to see a kidney doctor? So how does this looks on kidney biopsy? A kidney biopsy is that we go into your kidney. The kidney has two parts, one called the medulla, one, and the other is the cortex. The cortex is more superficial, and that's where the functional unit of the kidney is. It's called a nephron, and we have 1 million nephron per kidney. So once we do a kidney biopsy, we're looking at this, which is called the glomeruli. But more importantly, we look at the vessels, right? Remember we said that this layer on the vessels, the intima, gets thicker, gets bigger, hyperplasia. So those are signs of scleroderma in the kidney. So the primary changes in the kidney will be in the small arteries and in the glomeruli. This glomeruli is just a tuft of capillaries, tuft of blood vessels. And then characteristic is that proliferation and thickening that will lead to narrowing of these vessels. That this vascular lumen is so narrow that blood flow is not flowing through that. It's very difficult. So the kidneys are suffering that ischemia lesion. And it leads to this hypertrophy that we call onion skinning, which when you see onion skinning, that means that this is something chronic. So why this happens in the kidney, and this figure, it might be a little complicated to understand, but the kidneys will lead, this damage will lead to interstitial fibrosis, which means scarring of the kidney, right? We're going to have abnormal cells coming into the kidneys, and we're going to have this chronic vasculopathy, meaning that our blood vessels in the kidney are going to suffer damage. So scleroderma leads to this endothelial cell activation, that smooth muscle proliferation that leads to that hyperplasia and thickening, and there's growth factor release. Growth factor is going to make our vessels get thicker. So when we look at similar to this kidney biopsy, right? So these are other examples. We can have thrombosis, meaning like there's a thrombi that went into the kidney and caused an occlusion. There's going to be necrosis also in the kidney that could happen. Ischemia. So all of these changes could happen in our kidney, right? And it's very important when we do a kidney biopsy, it helps us to tell prognosis, right? If there's a lot of fibrosis and scarring in the kidney, then it's most likely that that patient is going to have permanent damage from the scleroderma renal crisis. If you don't have a lot of that fibrosis, there's more chances that the kidney is going to recover to the levels that it was before having this scleroderma renal crisis. So again, what's happening into our kidneys is that there's that blood vessel narrowing, there's a drop in kidney function, and then the kidneys will struggle to remove that waste, right? So how do we diagnose this? Blood pressure measurement, and again, blood tests, right? We're going to check for that creatinine, and we're looking for that change of more than 0.3 milligrams per deciliter that will tell us that there is a kidney injury. And then we also do some urine tests. We check for protein in the urine, for blood in the urine. The kidney has a membrane that is called the filtration barrier. And it's very, very tight and very selective. So it doesn't allow proteins to pass into the urine. Proteins should stay in the blood compartment and not going into the urine compartment. If there's protein leaking in the urine, that's a marker of kidney disease, that something is happening in that glomeruli that has damaged that membrane that is allowing these big proteins to get through the urine. Most of the time when we see blood or protein in the urine, we will recommend a kidney biopsy too. So there's not a specific diagnostic criteria for a scleroderma renal crisis, but again, it all goes along with the elevation of the blood pressure, right? So any acute increase in blood pressure in patients who have high-risk features, meaning patients who had that antibody, the anti-RNA polymerase 3, high dose of glucocorticoids, and whoever has had a kidney injury or kidney failure in the past 5 years, if we see that there's an acute increase in blood pressure or kidney acute kidney injury, then that patient meets criteria for a scleroderma renal crisis. That acute increase in the blood pressure could be a new onset elevation of blood pressure of more than 140, that systolic, and the lower number more than 90, or a change from your baseline of more than 30 milligrams of mercury in that systolic top number of the blood pressure, or an increase in the diastolic, the lower number that you see when you check your blood pressure, of more than 20 from your baseline, right? And if you're not monitoring your blood pressure every day, then you're not going to be able to catch this, right? At times you don't need to do it every day. Every other day should be fine. But you want to be able to capture these little changes, right? And bring that to the attention of your doctor. Then for those who do not have high-risk features, then you'll need those criteria that we mentioned, these two, and then any two of this, right? Plus one of this. So evidence of microangiopathic hemolytic anemia, that means that it's a type of anemia that is hemolyzing. Your red blood cells are hemolyzing, meaning they're dying and releasing all this stuff into your blood. We check some markers in the blood that will tell us if that's happening. Thrombocytopenia means that your platelets are low, right? So anemia, low platelets, and then evidence of organ dysfunction as damage to the eye from hypertensive or acute heart failure that happens from scleroderma renal crisis. And if we do a kidney biopsy, those characteristics that I show you that we can see in the pathology.
Doctor, the evidence of microangiopathic anemia, is that why you check the sediment in the kidney every so often?
That's a good question. So that's not why we check the sediment in the urine. We check the sediment of the urine to look for clues of any of this happening. So in the urine, we can see red blood cells that are dysmorphic, meaning usually red blood cells are round. Dysmorphic red blood cells, they look a little bit different. And we can see that in the urine. So if we see that in the urine, we think that, oh, you might need a biopsy to make sure you don't have any of this happening.
Basically, it's a tool to investigate further.
Yes. And this microangiopathic hemolytic anemia, this is happening to your hemoglobin, right? The red blood cells in the blood, not in the urine. So the red blood cells are dying. And we check some markers like LDH and haptoglobulin that will tell us if you're having a hemolysis or not.
So would you know that through a blood test?
Yes, through blood tests. Then your doctor will send some extra markers to make sure that you're not having that microangiopathic hemolytic anemia.
Are you having the anemia of the platelets also?
Yeah, so when we do a complete blood count, we get the hemoglobin level. If it's low, that means anemia. And then we get the platelet level. If they're low, that means thrombocytopenia. So if you have anemia in that complete blood count, then your doctor should send markers to rule out a hemolytic anemia. Hemolytic means that those cells are lysing, they're dying. And there's blood markers for that. Good questions. So for the diagnosis, this should be considered in all patients with a scleroderma, systemic scleroderma, who present with acute kidney injury, right? And that concomitant sudden increase in blood pressure. So the key here is, it sounds kind of easy, right? Oh, if your blood pressure is high and then your kidney failure, then you probably have a scleroderma renal crisis. But there's other reasons too, right? Why you could have acute kidney injury. So it's not always due to the scleroderma, right? That's why we do those other testing, for example, in the urine. Sometimes patients are not eating well or they're having issues with oral intake. So if you're not eating well and you're having vomiting, diarrhea, that could lead to acute kidney injury from dehydration and not really from a scleroderma renal crisis. A kidney biopsy is really not required to diagnose this. It's more of a clinical picture, right? Kidney biopsy, it will be a plus and will kind of like cherry on top for the diagnosis of this. But if you do have some markers like the proteinuria or hematuria that are concerning, then even if we think that you might have a scleroderma renal crisis, then we might want to do that kidney biopsy to make sure we're not missing something else. So how do we monitor this? So blood pressure should be measured on a regular basis, right? In all patients who have systemic scleroderma. And I would think that to be safe, you need to do this daily, right? Patients who have high risk. And then for the other patients that are not high risk, then you can do it twice weekly. So a persistent rise of 15 in the systolic blood pressure or 10 millimeters of mercury in the diastolic blood pressure, then should bring some concern, right? And it might need some extra evaluations. But none of this is going to happen if you don't do it at home, right? If you don't bring that to the attention of your doctor. So in patients who are already taking medications, because you can have a scleroderma and you can have essential hypertension, and you could already be on some of these blood pressure medications. So if your blood pressure sustainedly is more than 140/90 and it's not corrected with any dose adjustment or salt restriction, then that should trigger a further evaluation, right? And then we should measure creatinine at every clinic visit. So if you go to your doctor every 3 months, when they do the chemistry panel, the metabolic panel, the creatinine is there. So now you know that you need to go and look at your creatinine level, and you're going to monitor where's your baseline in the past 6 months. Might be 0.8 to 1.0. So if one day your creatinine is 1.5, that should be a trigger. So this is life-threatening, right? And it's a medical emergency. And it's going to require an admission in the hospital, and most likely the critical care unit. With our intervention, then you're going to end into end-stage kidney disease. That permanent damage to the kidneys, when it's more than 3 months, there's no way we can reverse that. And its mortality is high, right? So in some patients, when they reach end-stage kidney disease, mortality happens within 1 year. So our treatment goals are that rapid control of the blood pressure. We want to preserve that kidney function, and we want to prevent complications, right? So it needs a multidisciplinary team. And the main treatment for this are called ACE inhibitors, angiotensin-converting enzyme inhibitors. And in this graph, this is the angiotensin-converting enzyme right there that is converting angiotensin 1 to angiotensin 2. And this angiotensin 2 is the bad guy, right? We don't want this guy here because it will cause hypertrophy of your heart, right? It will lead to vasoconstriction, systemic vasoconstriction. Vasoconstriction means that your vessels are narrowing. And remember, the kidney is a tuft of blood vessels. It's going to lead to increased blood volume, sodium retention, fluid retention, and all the bad things, right? So we want to block this guy right here. And we use a medication called captopril in the emergency setting, in the initial treatment, captopril, because it acts very fast and it's short acting, so we can adjust it more easily versus giving you a medication that has a more long half-life, then it's hard to adjust. So we want to lower that blood pressure and we want to protect those kidneys. So captopril will be our initial therapy because it has a rapid onset and it has a short duration and it permits for that rapid dose escalation. Other ACE inhibitors like enalapril or ramipril may be used as well in that emergent setting, right? Once you're out of that emergent setting, then we switch captopril to a longer medication, longer half-life, right? Because you don't need to be on taking captopril 4 times a day, right? You want a medication that you can take only once a day. So some observational data have shown that ACE inhibitors are associated with greater antihypertensive efficacy, better preservation of kidney function, and lower mortality in patients with a scleroderma renal crisis. So I brought this graph here just for you to see what was our a stepwise approach when you are in the hospital and we're trying to bring down that blood pressure. If there's central nervous system involvement, meaning the brain or the nerves, like the in the back of the eye, we have this papilla. If there's edema on the papilla, then we're concerned that there's a CNS involvement. If you have altered mental status, then we're concerned that the brain has been affected. So if that's the case, we start captopril with these doses, and then we titrate up to a max dose of 300 or 450 milligrams a day. And if still your blood pressure is not well controlled, then we have to add an IV intravenous medication like nitroprusside, and then with this we're able to control that blood pressure. We should avoid using labetalol or any other beta blockers, and once your blood pressure is controlled, then we take off that IV medication, and then we keep you on only on the captopril, right? We don't want you to be on IV medication for too long. Why we don't use these two medications? Because they're associated with vasospasms. It means that it's going to make that vasoconstriction worse. So we usually don't want to use those in a scleroderma renal crisis. So fluid balance is very important. Remember, the kidney is essential to remove that extra fluid. If you have kidney failure, then you might become volume overload. We use dialysis if needed, if your kidneys are failing. When we use dialysis in a scleroderma renal crisis patients, we use it with the idea to be temporary, right? It's not a permanent treatment when we start. And then it's a case by case to decide whether the patient is going to be able to come off dialysis or not. And we avoid high dose corticosteroids. So we monitor the response. So we monitor the blood pressure. We assess kidney function, electrolytes, and hemolysis parameters daily, right, during therapy. And patients who are starting on ACE inhibitors, they will have a transient increase in the serum creatinine. But that's how it works, the medication. And if we see that, then we know that it's actually working. And then we have to monitor potassium levels. ACE inhibitors have that side effect of increasing potassium levels. And if you already have kidney failure, that also will put you at risk for high potassium levels. So we're monitoring all these parameters while you're in the hospital and while you're on treatment. So early diagnosis have better outcomes. And again, some patients may need temporary dialysis, and case by case, then at times, if it's too late, when the patient has come to the hospital, then they might end up with permanent damage. How can you help protect yourself? Well, monitor the blood pressure regularly. You need to report symptoms quickly, and you have to come to all your follow-ups, right? So we're right on time. So final takeaways, you got to know the warning signs. Early action saves life. And remember, you're a key part of the healthcare, right, team? So you guys, your input and your feedback is always very important, right? So all those things that you do at home, monitoring your blood pressure, looking at your labs, that's very important, right? So sometimes doctors are in a little bucket, right? Oh, I'm the kidney doctor, so I don't know what's happening over there with your heart, right? So you gotta tell us at times, hey, you know, I just saw my heart doctor and he told me that I have heart failure now. Oh, that's a very important key information, right? So at times we're a little close in our little bucket, but you guys are essential for that part of the healthcare team. Thank you. And if you have any questions, I'm happy to answer.